Hello, this is Alasdair MacLullich. Thanks very much to Adam and the other organisers for inviting me to contribute to this teaching weekend. I'm going to start with a bit of a discussion about the definition of delirium and the terminology issues that still cause a lot of trouble, and then a summary of what we know about epidemiology, pathophysiology, and then the main focus of the lecture will be the clinical care of delirium and then some content on future directions. So just to recap the DSM-5 TR, which came out a couple of years ago, and the key elements to this are A and B, with disturbance in attention and reduced awareness of the environment being what you need to see at the bedside, and then the onset being hours or days being a key part of a delirium definition. C is not that important because in fact almost every time if you have any inattention you're going to find many deficits in cognition and so on, which would be a product of problems with attention. One of the issues around delirium care that's really caused a lot of trouble in care as well as in science is all the different words that we're using to describe this condition. And apart from delirium in DSM-5, and it's been in DSM for many years now, many generations of DSM, these other terms are not official terms that appear in any standard, ICD or DSM classification, and yet they persist in the UK and outside of the UK as terms which kind of mean delirium mostly, and which then lead to lots of trouble with coding, with consistency in clinical care and so on. This is an example of the kinds of difficulties that can be observed is just separate bodies of delirium and encephalopathy research in this useful article from 2020. And as a response to this, Arjen Sloter and a few others, including myself, sought through a Delphi process to agree on some definitions, and this was supported by 10 societies, including psychiatric societies and neurological societies around the world, with these recommendations using delirium as a clinical syndrome, coma as a clinical syndrome. Acute encephalopathy is not a clinical syndrome, but it's the assumed pathobiological process which underpins the delirium or coma. And these other terms on the right, altered mental status and so on, are not recommended anymore. And this paper, which came out around the time of COVID, is just a case example of why we need to be consistent about terminology. You can see from this slide that despite the fact that many of the clinical cases, the syndromes that were being described were really, going to be delirium in nearly all cases, I would say, new onset psychosis, neurocognitive dementia-like syndrome, which is a new term as far as I could tell, and the word delirium didn't actually appear in this paper. So this meant that when people were trying to understand what did COVID look like when it presented, and in fact delirium was a very common presenting feature of COVID and ended up being part of Public Health England's diagnostic triggers for doing a COVID test before we had COVID tests for everybody. And this meant that all of the studies that were done around delirium and COVID were using a spectrum of terms, and it made it very difficult to make sense of it all. And this is the case with many other areas of delirium research. The reason that I'm advocating, and especially to this audience, that we don't use terms like encephalopathy or acute encephalopathy as the diagnosis is because when you use the word delirium as per DSM-5, the official criteria, this leads to a more orderly approach to what we're doing. It allows us to draw from delirium literature. It allows patients to be informed of a consistent diagnosis, to be given leaflets. It means that NICE guidelines, the SIGN guidelines in Scotland and other guidelines using the word delirium can be applied. There isn't a guideline for obtundation. There isn't a guideline for, these other terms that were used in that Lancet study. So I really am using this platform as a plea that we use the word delirium and don't use words like altered mental status and encephalopathy if it meets the criteria in DSM-5. I'd like to just give a brief outline of what we know about the epidemiology of delirium. So what we do know from decades of research now is just what a big deal it is in terms of the day-to-day care of anybody working in acute settings, with about 1 in 5 of older patients in hospital, 1 in 4 in some studies, meet criteria for delirium. It's quite common in older ED patients as well. Hip fracture is a notorious setting where you see a lot of delirium, about 25% in the National Hip Fracture Database in England, which is several, tens of thousands of patients per year. About half of patients in ICU have it, and it's also very common in patients presenting to hospices and also in the context of dying. This has been pretty well studied in terms of these broad risk factors, old age, dementia, and frailty being the most important. Previous history of delirium is also a well-known cause. Something that's become apparent in the last 10 to 20 years is that delirium is an independent risk factor for multiple short-term and long-term adverse consequences. So in the short term, that delirium 2 to 3 fold increase length of stay, much higher mortality. In one study we did with the 4ET, if you had a positive 4ET, then your risk of being dead in a year in the over 65s was 50%. So 50% mortality in a year with a positive 4ET at the front door in hospitalized patients. People with delirium get aspiration pneumonia quite a lot. They suffer a lot of distress, which I'll come to later, and have lots of other consequences. Dementia we'll also talk about soon, but it's basically a condition which is a marker for a patient having a much longer and more difficult stay in hospital and often requiring new care home admission and so on. So this is an important study led by Daniel Davis, who's in UCL now, where people with delirium who didn't have a history of dementia, this is a population study in a city in Finland, had a much higher risk of dementia in the future. Also, we know from this population of patients with existing dementia that delirium seems to be associated with acceleration of the dementia, in this case of memory impairment getting worse over time. I mentioned these mortality figures earlier, but just to say that as well as there being 50% mortality at a year, much of that mortality, as you can see from this graph, is happening in the early part of the admission. These are unadjusted figures, and of course there are going to be many other concurrent acute causes of this, but the point here is the fact that delirium is a marker, of especially in older people, of a patient that's a lot sicker and is much more likely to do worse. Another problem that I think is not all that well appreciated is persistent delirium, where people with delirium may recover quickly, maybe 3 to 5 days being the median duration of delirium in some studies. It may be a little bit longer now with the older populations that we're seeing, but many people have this long tail of either no recovery at all or only partial recovery. So we're really talking about delirium as being in the camp of being a brain injury, where a bit like acute kidney injury, where the recovery is often incomplete after the acute episode, even if there's some improvement. And I'd like to cover a little bit about what we understand about the pathophysiology of delirium. So this simple diagram just shows in a way the challenge of trying to understand what the pathophysiology of delirium is, because on the left you have the acute triggers, which are usually outside of the brain. These cause some kind of change in the brain, which is now termed acute encephalopathy, and obviously there are going to be a variety of these encephalopathies underpinning delirium. And then we have the behavioural syndrome, which is what we use to make the diagnosis on the right. This review article published in 2020 gives a good overview of what was known at the time that was written. Since then there have been a couple of advances which I'm going to come to, but you can see from this that there are multiple routes to a delirium diagnosis. These can include systemic triggers, so obviously if you deprive the brain of oxygen, if the blood pressure goes down, then that's going to affect a lot of different functioning of the brain, and it will often manifest as a delirium. Then there might be direct effects of drugs, for example, and there may also be secondary effects, peripheral inflammation triggering CNS inflammation, which then may also be contributing to delirium. And many people hypothesize, you can see in the bottom right there, that delirium may ultimately, in many cases at least, be caused by a kind of loss of integration of all brain networks, and this sometimes has a parallel in EEG research that's been done. One of the most prominent hypotheses around the pathophysiology of delirium has been that systemic inflammation, for example infection in the bladder or in the lung, can lead to triggering of inflammation in the CNS. And this slide summarizes the work by Colin Cunningham, who's been the leader in the field for really a long time now, who uses a model of prion disease in mice and then showed over a number of different studies that peripheral lipopolysaccharide leads not only to a delirium-like state over a short period, but also can lead to acceleration of neurodegeneration. This is a large CSF study just published in JCI, which looked at the kynurenine pathway and adds to the weight of evidence linking CNS inflammation induced by peripheral causes as being a potentially important mechanism of at least some delirium. There is also mounting evidence that there might be actual measurable brain damage during delirium. This, of course, would fit with the epidemiological evidence that delirium is associated with a much higher risk of future dementia and so on, but we've been lacking up until this point harder evidence that people with delirium may actually have active brain injury at the time. And this study of neurofilament light, published in Brain 3 years ago, is one of a few studies looking at this. A very old hypothesis dating from the 40s is that there's cerebral metabolic insufficiency as another potential cause of delirium, and there is a strand of evidence now beginning to build up with this. One of the source of evidence is PET studies, as shown here. This is another CSF study from the same group based in Oslo, which found that in patients with delirium versus no delirium, there were multiple markers of impaired energy metabolism were found, and this has just been published in Brain. So with delirium being very common, affecting 1 in 4 hospitalized patients over the age of 65, and the very high risk of future cognitive impairment, including dementia in people with delirium or acceleration of existing cognitive impairment, it's clearly very important for us to understand what is underpinning this link. And those of us who've got experience of working with acutely ill older people in hospital will probably have seen people with many of these kinds of problems which might be injuring the brain. For example, as I mentioned before, hypoxia, inflammation, hypotension, as well as psychological stress induced by lack of stimulation. Sleep deprivation is also extremely common. All of these things, I've got animal model parallel work which shows that the brain can be injured, by any of these things, and many other mechanisms as well. So I think this is going to be something that we look at more in future because of the scale of the problem, and also because some of these insults may be preventable. Now I'd like to move on to discussing the clinical care of delirium. So we have these 3 fundamental pillars: diagnosis or detection, treatment, and prevention. So just to recap DSM-5, the key things being demonstrating a disturbance in attention and reduced awareness of the environment, which is not necessarily a particularly well-defined feature, but not being engaged, not being able to hold a conversation, being sleepy, these kinds of features are said to map onto this construct of reduced awareness, and of course the demonstration of acute change. In terms of day-to-day practice, the tool recommended by NICE since January 2023, and also SIGN and many other guidelines and pathways around the world is the 4AT. This is now the best validated delirium tool in the literature, and you can get more information on it on the website there. Delirium has quite a wide differential diagnosis, although many of these conditions are much rarer than delirium. Of course, there are definitely cases where people presenting with strokes are misdiagnosed. I do have a worry that non-convulsive status is underdiagnosed as a cause of delirium. Catatonia is also a condition that is mentioned quite often as something that is missed in the context of a delirium diagnosis. The two can coexist though, of course. And these other conditions, like autoimmune encephalitis, it just requires an eye for a patient who's not presenting in a typical kind of way, maybe with a more subacute course or with certain kinds of features that don't quite fit with the delirium. So assuming that the diagnosis is delirium, then it's not just about saying that this patient has delirium, it's also about recording what the features are like, because it is quite a heterogeneous condition, and what the spectrum of features in a given patient will influence how you manage the patient. In particular, if they are very sleepy, then you have to manage the risk of aspiration pneumonia. And also people with severe distress, with psychosis, need specific management of those features. Now I'd like to move on to delirium treatment. A challenge in describing or in discussing the treatment of delirium is just the sheer number of potential targets that one has when looking after somebody with delirium. So delirium treatment involves multiple different aspects. Classically, we say treat the causes or treat the cause, and that's still obviously the case. But then in the context of treating a pneumonia, for example, then the treatment of delirium would also involve treating the associated insults of that condition that are likely to be affecting the brain. Some of them are listed there, especially hypertension and hypoxia. Then we have what's happening in the brain itself, which is what we term the acute encephalopathy underpinning the delirium. And currently we don't have much in the way of treatment that is interacting with pathways or other aspects of brain functioning. Just antipsychotics and benzodiazepines would be two examples of that, but we don't have at the moment drugs which would for example, prevent neurodegeneration in somebody with delirium, or are neuroprotective in any way. Then you might also be treating the symptoms, the core delirium features, the patient experience, also the short-term complications. So if somebody is a high falls risk, for example, you might be managing the falls risk in that patient. And then, of course, the longer-term outcomes, which are, as I've said earlier, very well documented. So that might involve, for example, a kind of rehabilitation, kind of akin maybe to the rehab that you would do with somebody with a traumatic brain injury or subarachnoid hemorrhage. So to try and capture all of these different aspects, the SIGN guidelines in Scotland from 2019 has these different aspects of delirium care. I'll consider some of these in the next few slides. Before I go into some of these aspects in more detail, I'd just like to mention that although the mainstay of delirium treatment is to provide an analysis of what the causes are, to treat that, and then address those different aspects such as the complications of delirium and monitor for recovery and so on, this sort of multi-domain package of measures, or bundle of measures you might call it, has really hardly been tested in the literature, with a very small number of RCTs as shown up there in the top left, a few QI studies, and interventions have been this kind of multidisciplinary approach of treating the triggers and so on. Other interventions include education or single interventions like physiotherapy. The first step in delirium treatment is always to consider whether the patient has an acute life-threatening cause, which could, for example, involve a large opioid dose that's been given in the context of a hip fracture, for example, or very low blood pressure, or hypoglycemia, or hypercapnia. And this discipline of always checking for that is very important, because we know that delirium is associated with very poor prognosis, often in the very short term. The next stage is the classical, instruction to treat the causes. And just the quick point I'd like to make here is that often there's more than one cause running in the same patient at the same time. So it requires a sort of top to toe analysis. For example, dehydration, dihydrocodeine, and acute kidney injury might be opioid toxicity, but the dehydration and the opioid toxicity are both important in treating that, as well as whatever has led to the point where the patient is getting the dihydrocodeine. The next thing I'd like to focus on, and taking a bit of time over this, is distress. Multiple studies now show that people with delirium often are experiencing severe distress, and often this is not detected in clinical care. This Am I Dead was written by a patient during an episode of delirium. So in a study we just did, we used the quick distress assessment, very simple tool to look for the level of distress in patients with delirium. We found that many patients were experiencing distress either through non-verbal signs or verbally reporting it, but it was often not mentioned in the notes. This was a study of 50 inpatients in orthopedics and geriatrics wards, where mood was just not mentioned very much as part of the evaluation of the diagnostic process for delirium, but also the recovery. So it's something that we're missing, even though we know from other studies that delirium is commonly associated with distress. So I'm now looking into a more formal approach to detecting and managing distress as a formal element of delirium care. So the first thing is to find out if the patient is distressed, and that of course involves observation, frowning, fear, all the different signs that you might pick up, and then also just asking the patient, are they frightened? Is anything concerning them? Do they feel safe? There are many questions that one might ask, and it's very common in my experience, if you ask these questions, that patients will report that they do indeed feel frightened, or they experience a lot of anxiety. Once you've done that, then there are many different potential causes. There are physical causes like urinary retention, really common in hip fracture patients, and people sometimes get haloperidol or other treatments that are nothing to do with urinary retention, but that's the root cause and it's just been missed. Pain, of course, is very common in acute hospital patients, and the list goes down there. So then it involves a specific plan to address these remediable causes, the ones that you've managed to find. But alongside that, the distress itself, I think, requires specific treatment. So trying to develop this as something that might be testable as a way of enhancing delirium care, especially in people with distress, but in fact all people with delirium. And as I said before, there's a lot of accounts of people being distressed in delirium, and alongside that there is also a lot of papers which have shown that people often remember how they're spoken to, how they're treated during the episode, and this often can affect how somebody feels during the episode and their memory of how it went, with people having positive experiences. Well, people held their hand and told them what was happening, explained, and other people would just be speaking over the patient and not explaining anything, which increased the distress. The line at the bottom, that porter was so kind that if I won the lottery I would give him my winnings, comes from a colleague of mine, a doctor in her late 20s who unfortunately developed delirium when she was in the ICU, and when she was being transferred out of the ICU she was extremely distressed and scared, and the porter stopped the bed and held her hand and told her where she was, what was happening, that she was just being transferred to another ward and that things were going to be okay and that she was getting better. And this colleague said that she was extremely affected by this in a positive way, and years later remembers that conversation and has brought that into her own practice. So I find that a very inspiring story, and there are many other stories like that where it really does matter how we speak to people with delirium. So this is something that is being, developed and tested at the moment. So the concept of therapeutic engagement as applied to patients with delirium, where we understand more about how that patient is feeling through informant history, which might be the family member, or also our own observations. If it's possible to speak to somebody with delirium, it isn't always possible, but at least say who you are and ask about how they're feeling, explaining to people where they are in a very clear way with short sentences. And if somebody is distressed, then trying to reassure about, that they have delirium, tell them they have delirium. Sometimes also I find it useful to change the topic of conversation a bit to what I'd call anchoring in neutral or good memories. It might be where did you go to primary school, where did you grow up, what sport did you like when you're growing up, and just trying to shift the focus away from any distress that they might be feeling at the time. There's some evidence that certain activities like cognitive engagement, just mobilization can really be helpful. Physiotherapists have a lot to offer in this kind of situation because they have so much skill in how they interact with patients, and simply just the interaction, getting patients to stand up and walk around, I think, if it's appropriate, of course, but I think that can be a very helpful intervention. And just encouraging the whole team to have this approach of explaining who they are, telling the patient what's going on, that they've got delirium, and trying to encourage them out of this. There is a role for drugs in delirium treatment, with the caveat that, of course, because we don't have any direct evidence of consistent neurotransmitter disturbances, for example, that you always give haloperidol. I think that's a silly idea which somehow has become a norm in some units, but obviously there is no standard drug treatment for delirium, and never should a drug be prescribed just because somebody has delirium. I do think, though, that in some situations where the patient is very distressed, or there's a dangerous situation like they're pulling the tube out in ICU, or and other circumstances like that, or if they're resisting all care and they need an antibiotic, then there are indications for the use of drugs. And I would say that one dose or a couple of days worth of risperidone and haloperidol, it appears to work in some cases, although there isn't actually any evidence of this. There are no studies which have looked specifically at the effects of these drugs on distress, psychosis within delirium. All evidence, in fact, shows that these drugs, in a general sense, don't improve the delirium, but I think they may improve the distress element of delirium. Of course, benzos are a potential second-line drug here, but they have a lot of side effects in people with delirium, including increased falls risk, and it may even make the delirium worse from a cognitive standpoint. Another thing that we notice a lot in various studies is that people with delirium are often put on haloperidol for many days or even weeks, and some are even discharged on haloperidol, even in the UK, which is an absolutely scandalous situation. It's not a treatment that somebody should be on for weeks for delirium. It's really a treatment that lasts a couple of days, and if it isn't working, you need to do another type of intervention, either another drug or more therapeutic engagement. So we talked about the initial check for acute life-threatening causes, a more systematic look at causes and distress. Other aspects include preventing complications. These can include falls, pressure sores, dehydration, malnourishment. Many cases now of patients with persistent delirium, especially in non-specialist units, who just don't eat for weeks and get dehydrated, and it's a ripe for medical legal challenge, as there are many such cases coming through now. So it's a very important thing to ongoing active management of somebody with delirium, because they're in a very vulnerable state. Communication, I mentioned that before in the context of distress, but providing leaflets on delirium is a very useful intervention, and it's very important that you tell the carer this your loved one has delirium and explain what it is. Otherwise, they're often in a very puzzled and perplexed state if this isn't explained. monitoring for recovery is very important. So repeated 4ATs, for example, we've just completed a study showing that it's valid for that. That'll be published hopefully next year. Rehabilitation during delirium, so ongoing physiotherapy if they were going to get physiotherapy anyway. Don't stop the rehabilitation just because somebody has delirium. Try and continue doing it. The rehabilitation of the delirium itself, as well as the general rehabilitation that was planned anyway. And with respect to dementia, so I was involved in a study published a few years ago now that looked at the informant questionnaire for cognitive decline in the elderly, and it is valid as a test of dementia in patients with delirium as long as you specify to the person who's being asked the questions, the informant, that it refers to the period before the delirium emerged. But there used to be a kind of a belief that you could never diagnose dementia at the same time as somebody had delirium, but using informant history you can certainly get to the point where the likelihood is established, and then follow up at 2 to 3 months might be a reasonable thing to do in some of these patients. Delirium prevention is quite well evidenced. There are several good quality studies that have shown that if you avoid harming the patient's brain in hospital through making sure that they don't become dehydrated, that they eat enough, that they sleep enough, that they're mobilized, that pain's controlled, basically avoiding the kind of harms that are very common in hospital, then you can prevent some delirium. It is important to point out though that most delirium is present at the front door. About 70% of delirium is already there when patients arrive in acute hospitals, and of the 30% of delirium that arises after admission, around a third of that can be prevented with good care. And much of this is just about organised, good nursing care, as shown in the list from the SIGN guidelines there. I'd just like to conclude with some thoughts on where we're going in the field. So the first thing is, of course, that we need to apply what we know now. So we know that we can diagnose delirium. The 4AT is one tool that works well. In the hospital I work in Edinburgh, about 85% of patients get a 4AT at the front door, and about 15% of these are positive, so it's about right. And some other places around the world also show effective delirium detection, but many places show very little. And across the UK, it's probably still less than a third of delirium is diagnosed in general, which is really quite a shocking situation that we just can no longer accept as being the norm. Once the delirium is detected, then I think we need to recognize that our approach to treatment is often just nothing other than just maybe treat the UTI that you think might have caused the delirium, and that's it, and have a much more comprehensive set of measures that treat the causes, protect the brain, and also reduce the distress associated with delirium. And then, of course, where possible, to reduce risk of delirium through good general care, systems of care, and implement these and check that they're implemented. I would like to say though that we have some encouraging data from UK, and with the NICE guidelines were published in 2010 and the SIGN guidelines in 2019, and in fact there's been a very large increase in delirium coding. This is whole population data, so all hospitals in Scotland and England showing about a quadrupling of delirium coding between 2012 and 2020. So we now know that it's possible to do better at delirium coding. So after many years of delirium being a condition that had not much attention paid to it in clinical world or in research world, things have really changed in the last 5 to 10 years, and we're now in a position where I think there will be a lot better understanding of delirium in the next 10 years or so, coming from these different domains of research work. Epidemiology research already fairly strong, I think, within the framework of delirium, but I think with electronic healthcare records and better routine detection of delirium, we now have the possibility of doing large-scale routine data studies, and we're doing some in Edinburgh just now, where a lot of people get the 4ET at the front door. It's recorded, and then we can then look at, for example, what predicts worse outcomes in the population of people who have delirium. That's something that's not known that well, and so on. We do need to do much more work on systematizing general treatment interventions, so just a formal approach to triggers, protecting the brain, managing distress, avoiding complications, monitoring for recovery, communicating with families, and so on. Given that delirium is such a strong risk factor for dementia, I think that work looking at why this might be is going to be actually a very important contributor to the dementia field in general, especially if we can uncover pathways that might be druggable for neuroprotection. So the future might be that we have good detection, we have good general care, and then built on top of that, we maybe have trials that involve new forms of drug interventions that might improve, energy metabolism in the brain or reduce neuroinflammation. And there are actually a couple of trials that are now beginning to run looking at that. So it's an exciting time, and it has the potential to reduce rates of dementia post-delirium, I think. So hopefully in the next 10 years we will see some product from this. Diagnosis, we have clinical tools for bedside use based on behaviour, like the 4ET or the confusion assessment method. But I think we're now entering a phase where EEG will be beginning to become something that we use in delirium diagnosis. There are commercial products that have been well validated, which you can use, and some centres are already beginning to use EEG for delirium detection and for tracking of recovery, for example. It's not, what you see in an EEG isn't identical with the clinical diagnosis, but it overlaps, and it may be a subtype of delirium that we can see that's got EEG changes that may have a worse prognosis or may respond to different kinds of treatment. So I think that's going to be an important step forward in improving recognition and monitoring of recovery of delirium. Blood biomarkers, we're not quite there yet, but it might be that we have subtyping options with inflammatory markers, for example, or neurofilament light as damage markers, and that will allow us to know if we're dealing with a patient who's got a worse prognosis and needs more follow-up. And finally, I think that given that distress is such a big element of delirium care, that we should be doing drug trials which look specifically at alleviating that distress. Even just a simple study of risperidone, small doses over a couple of days, does that work versus not giving it or giving a different kind of intervention? I'd like to conclude by just advertising World Delirium Awareness Day, which has been running since 2016. It's a big deal in mostly social media presence, showing people all over the world. People have delirium teaching days, events, and so on. And the website Delirium Day supports our efforts for this event, and you can also find out more about it through following the World Delirium Awareness Day Twitter account and my account as well. And to also advertise the Delirium Society meetings in 2024. The next one is in Sacramento in June, and the European one is in The Hague. Australia has a meeting every 2 years, and the next one's in Cairns, July 2025. Thanks very much for your attention.